Good afternoon, everybody, and welcome back to Grand Rounds. Before we start today, I'd like to take just a quick moment to express appreciation to Avela Bank for their continued very kind and generous support of the CME programming here at Mary Greeley, and also to introduce Rex Rorson, who had a couple of introductory remarks. And so please join me in welcoming Rex.
Thanks, Dr. Hallberg. Hi, good day. I am Rex Rorson. I'm a mortgage loan officer at Avela Bank, and I came to Ames in 1981 to go to Iowa State, stayed here, met my beautiful wife, had 3 children, all born here at Mary Greeley, and seen a lot of changes in Ames over the last 45 years, and certainly a lot of changes at Mary Greeley as well, with the expansion of birthways, the new mental health services expansion, and the new surgical center. Also brand new, partnered with McFarland. Mary Greeley is here to serve the needs of Ames and Story County now and into the future. And I started Avela Bank in 2009. Back then it was First American Bank. And even back then, we were a sponsor of Grand Rounds. Realized the benefits that hospital can have on a community, and this program here in educating both providers and the public on a lot of topics is important as well. So when Avela Bank purchased First American in 2019, there was discussion about where are we going to be allocating funds, and I'm glad to say that Avela Bank has continued to see the value of Grand Rounds, and we are proud to sponsor Grand Rounds this year and into the future. Thanks so much.
Thanks, Rex. Today, I have the pleasure of introducing Dr. Andrea Weber. Dr. Weber is board certified in internal medicine, psychiatry, and addiction medicine. She attended medical school at the University of Iowa and also received a master's in medical education there. She stayed in Iowa City to do her internal medicine psych residencies. She is currently clinical associate professor of psychiatry and internal medicine at the University of Iowa. She's a program director of the internal medicine and psychiatry residency program at the University of Iowa and assistant director of the UI Addiction and Recovery Collaborative. As you can see, she's quite busy, and we very much appreciate her taking time today to join us for a review of medical cannabis. And please join me in welcoming Dr. Weber.
Thank you so much for the introduction. Thank you for having me. I'm just getting my stuff set up here. All right, so pleasure to be here. Hopefully to kind of give an update about medical cannabis, especially as it pertains to Iowa. So this is going to be a pretty locally oriented talk, especially around the state's medical cannabis program. My goals with you today is just to be able, when you leave the session, to feel more confident and capable of actually having kind of conversations with your patients or people who are utilizing the medical cannabis program, who are maybe interested in it based on things like the type of products that are available, the qualifying conditions, and the route of use. We're going to talk about kind of just how the program works, just to an understanding from healthcare providers, how we get people registered or how people can access the program. And then I also just want to point out the kind of limitations of the program, especially as it pertains to certain social and functional or social and legal issues around employment and education. As far as disclosures, I don't have any pertinent financial disclosures related to this material. By state law, our Iowa Medical Cannabis Program has a board that's filled with certain types of physicians, and I represent psychiatry on our Iowa Medical Cannabis Board. I will be discussing non-FDA approved uses of different cannabis products as more just a kind of an entryway into what's available in our state program. I will make the disclaimer that talking about cannabis, especially from a medical perspective, can be extremely polarizing. There's this tendency of all good, all bad. I think there's a lot of unknown around medical cannabis. And so if you leave this without maybe a lot of great answers, I will say that part of that is because the amount of great research in this area is pretty minimal, partly just because of its current federal status. With this session, you should have received a PDF that is at least a summary of some evidence specific to types of medical cannabis products, dosages related to Iowa's qualifying conditions. I am not going to be going over that or addressing that directly, but I did want you to have that available to you to review, and hopefully that's helpful to you kind of going forward with your practice. So I'm a big historian when it comes to drugs, drug policy, how certain substances have been utilized over the course of human history. And I think cannabis is a very interesting substance to talk about because there's so much of our historical cultural ties that get wrapped up into how a certain culture views or utilizes a certain substance, both for medical and non-medical purposes. And so, the earliest uses of cannabis have dated back to 4600 BC, mainly in kind of our Eastern European countries. Its first recorded medical use of cannabis that we have was actually 2700 BC by one of the emperors in China at the time. It was kind of documented as being used for almost everything, like vaginal contractions, eye issues, epilepsy, pain, and even grief. So similar things to we used it before, but then also maybe a more ubiquitous use of cannabis as a medical treatment, if you will. If we fast forward to more modern times, Western medicine, cannabis was really introduced as a medical form of treatment by Dr. William O'Shaughnessy. That was in the 1800s. He was also the physician who kind of created the IV saline as a way to help treat cholera outbreaks. And so that was kind of one of the entryways of cannabis into Western medicine. Now, between like 1850s and 1930s, if you were a physician in the United States, it was very common that you researched or would even utilize or potentially recommend that your patients would utilize some form of a cannabis product. They were widespreadly available, dispensaries at certain shops on the street. So a little bit, less regulated, more available, more thought to be utilized for its medical properties. Around kind of the 1910s, 1920s, we had a growing anti-Mexican sentiment that was growing in the United States. There was the Mexican Revolution going on. There was a large immigration that was happening from Mexico into the United States. And it was noticed that people from Mexico often used a substance that was called marijuana, based in their language. They used it as medicine. They used it to relax. And this was especially pertinent because during this time, we're in the thick of prohibition where alcohol was not necessarily as available. And so cannabis and this marijuana was kind of seemingly more utilized in that way. An anti-Mexican sentiment started to grow. There was messaging sent out about kind of how these dangerous Mexican immigrants are using this marijuana and it's making them lazy. It's making them not great citizens for our country. And what was interesting around that time, it was that actually Americans by and large didn't necessarily know that marijuana was pretty much the same cannabis that not only they were familiar with from a pharmaceutical perspective, but it was also kind of the same substance to which hemp fiber was kind of grown and utilized. So there was a big disconnect in kind of the broad mind around the difference between cannabis and marijuana, or the fact that they were the same thing. In May of 1937, in discussion about a new law that was being proposed called the Marijuana Tax Act, Dr. William Woodward, who's pictured here, he was a physician. He was the main attorney and chief legal counsel for the American Medical Association at that time. He actually testified in front of Congress, somewhat in opposition to this new tax act. And I just put in quotes something that I think in some ways we're still struggling with, in the sense that we can't do great research. And so he just said to the Congress, to say, however, as has been proposed here, that the use of the drug should be prevented by a prohibitive tax, loses sight of the fact that future investigation may show that there are substantial medical uses for cannabis. Basically, the act passed, and over the next 5 years, or 5 years into the future, most medical products derived from cannabis were pretty much unavailable in the United States. United States drug policy had kind of commonly been that we're going to create a tax act where you have to get a special coupon or voucher to have this substance. The government would basically never issue a voucher or some sort of waiver for this product, in which case it would basically disappear through a tax act. Fast forward to 1970, the Controlled Substances Act took over for the Marijuana Tax Act. Cannabis was a Schedule I medication at that time, and it remains there to this day. And so again, I think talking about historical references, cannabis in particular, there's a lot of things that fed into how we view cannabis, but also kind of sometimes how stagnant research has been around both cannabis itself, but then also the endocannabinoid system that we think plays a role in a lot of different bodily functions in the human body. All right, I'm gonna transition just to going over cannabis as just a brief overview. So cannabis is a plant. It's part of the Cannabaceae family. It's kind of traditionally been split between different strains. So you have your sativa, your indica. I would say most commonly, a lot of these strains are now hybrid, and so it's very rare that we have kind of very isolated pure forms of kind of the sativa and indica as different strains. Cannabis as a plant includes a lot of different cannabinoids. We focus a lot on THC and cannabidiol or the CBD, but there's a lot of other compounds that exist in the cannabis plant that either we don't understand or we haven't identified yet. So sometimes we call them terpenes or flavonoids. There's just a lot of different things that we don't quite understand about cannabis, especially when it's consumed as a whole product or a whole flower. I do want to clarify because I think this gets confusing. Hemp is cannabis. Hemp is a type of cannabis that by definition contains less than 0.3% of THC. So sometimes I hear that hemp isn't cannabis, they're different. They're not. Hemp is a type of cannabis, but it is still technically cannabis. It just is a type of cannabis that has very low levels of THC, kind of just based on its properties. If you think of a cannabis plant, the ratio or the total amount of CBD compared to THC varies based on if you're talking about a female or a male flower. If you're talking about different strains, again, we talk about that hemp product. But then also just where in the plant people are consuming it. So for example, the highest level of THC is going to be in the female flowers, so the very top of the plant, if you will. And the lowest levels of THC are going to be seen in like the seeds and the roots. So basically, as you move down the plant, you're going to have less THC concentration relative to CBD as part of that plant. Cannabis comes in a lot of different formats, formularies, ways that people have created it, consumed it. And I'm just going to kind of introduce a few different types. So there's different types of concentrates. There's things like hash oil, dabs, waxes. By and large, these are basically viscous masses of concentrated compound where the cannabis plant has been treated with a solvent, oftentimes butane. And it's kind of the butane has allowed us to extract only the really concentrated compounds associated with the cannabis plant. That mass is usually then ingested either orally, sometimes it's vaped or smoked. Again, when people are talking about dabbing or waxing, they're usually talking about hash oil that's been treated with butane and then subsequently is kind of ingested in a really concentrated form. We also see cannabis utilized either directly in edibles, so we see cannabis flower added to a food product that's then ingested, or sometimes there's cannabis that is added or created with either butter or oil, and then that butter or oil is used to make a food product that is subsequently ingested. So for example, if you wanted to make cannabis-infused butter, you would just take unsalted butter, ground up cannabis flower, and add water, and you can pretty much make a butter that you can subsequently utilize in various types of cooking products. I want to point out edibles, but edibles are a cannabis product that pose a lot of challenges, both to kind of manufacturers and consumers. Oral ingestion of cannabis is the slowest onset of action, as is with how we ingest, any substance or medication, just kind of a slow onset. Sometimes that leads people to take too much. The body also converts THC to a more active component of THC called 11-hydroxy-THC. That's created in first-pass metabolism. And so when you consume orally, there's a later onset, but there's actually a different active metabolite that gets created, in which case sometimes people experience oral cannabis very differently than they might if they were simply smoking it or vaping it. Edibles are also a pretty common source of public health issue, especially for places that have more common recreational use or recreational product available. As you can see in the picture, they tend to look like candy. They're very colorful, they're flavored. They send a lot of mixed messaging, especially around pediatric ingestion. And so a lot of states who have more broad programs have spent a lot of time trying to regulate edible products looking like more commonly consumed non-cannabis products, trying to reduce the risk of unintentional ingestion, especially by pediatric populations. I think it's important when we talk about cannabis just to put it into perspective of other substances that are both regulated and unregulated, legal and also not legal in the United States. And so This is just a chart. The y-axis talks about what's the risk of someone developing a dependency on this substance versus the x-axis, which is what is the risk of someone having an acute dose that ends up being a lethal dose in that way. And you kind of see that cannabis is kind of considered a low moderate risk of dependence potential. It's very low when it comes to the risk of, things like overdosing or having a lethal dose of a substance. And it's very low risk on both if we compare it even to things that are both regulated and legal in the United States. We think about even caffeine, nicotine, alcohol. And again, I don't say this to say that we should be more prohibitive or anything like that I just think it's interesting to reflect that sometimes our drug policy or how we see different substances doesn't always get associated with the actual risk of that substance. And so just kind of putting things to perspective. I also think it's good for us as medical providers to keep this in mind, because I think it just allows us to have more informed conversations with people who sometimes have very strong opinions about their substance use and which substances are considered safe and legal versus unsafe and illegal subsequently. Another thing that plays a role, I think, into medical cannabis use and the growing availability of cannabis programs is just that we know that a lack of a legal regulated supply of cannabis kind of throughout the country from a federal level tends to lead to more unregulated, more potent versions of that substance. And we see that, a lot over and over again through history. We saw it with alcohol during Prohibition. We saw it during opioids when we went from opium to heroin to things like fentanyl currently. Just a more potent version, the more that there's demand for it, but also a illegal, not illegal or regulated drug supply. And we see this with cannabis too. So this is just a graph showing that when the DEA has seized different amounts of cannabis and they've kind of tested it as far as the relative percentages of CBD and THC, you can kind of see that we're seeing the amounts of THC go up as the percentage of CBD goes down. So just if THC is primarily considered as the more addictive, the more neurologically, psychiatrically active component, the part that causes intoxication, if you will, we're seeing products that are much more potent in that way. There's some estimates that you would have to consume basically 15 joints, if you will, of cannabis that was around in the 1960s to get the same amount of THC in one joint of cannabis that's available right now on the unregulated drug market. This is, the policy around, state by state policy is ever changing when it comes to whether people have access to a medical only program, whether there's actually adult recreational programs part of each state. This is the most recent graph that I found from the National Conference of State Legislatures. They do a pretty good job of keeping track about how state medical cannabis laws change. So this is taken from a couple weeks ago. Basically, you can see that Iowa in this orange is one of 8 states, and we are considered as only having a CBD and low THC program available. So that's kind of where we sit in the rest of the country. You can kind of see that there's 17 states in that yellow color. So these are people that have comprehensive medical programs. So think of it as higher amounts of THC available through their medical programs. And then also, considering places that have both an adult recreational program as well as a medical program, that's a lot of states in this green. A couple states with still no, formal program, whether it be recreational or medical or not. I will say that the states of orange are going down, the states in yellow are going up. So we're definitely seeing, a shift statewide of states having more access to cannabis, whether it be through a recreational program or a medical program, kind of over the course of a few years. All to say that policy, these programs are being created much faster than I would say we have science or research for them, and definitely outpacing any changes to federal law around cannabis, which gets a little murky and a little complicated. Okay, we're gonna transition now a little less about cannabis broadly and a little bit about kind of how we conceptualize cannabis and from a medical perspective. So, our bodies, all vertebrates, to be honest, have an endocannabinoid system. And this system has really only been discovered, and I would say barely discovered at this point, but it wasn't really discovered until the 1980s or so. So it's not that much information that we really know about. The primary function of the endocannabinoid system is thought to kind of really help to regulate a lot of different types of bodily homeostasis. And we'll talk about that a little bit more, excuse me. The first receptor, the CB1 receptor that was found to be part of the human endocannabinoid system was actually found in 1988. This actually was after we already had our first kind of FDA-approved version of a cannabinoid to treat from a medical perspective. So we didn't necessarily even have the receptor identified before we had this medicine that we were allowed to utilize for a couple things. It's thought to be it's one of the most abundant G protein coupled receptors in the brain. It's very heavily isolated in the brain. So you can kind of see it's all green or all blue. CB1 is very heavily situated in the brain. A few years later, so in 1993, the CB2 receptor, our second receptor of the endocannabinoid system, was discovered. This was really found primarily in the immune system. So we saw it in immune cells, we saw it in the spleen macrophages. The CB2 receptor is not necessarily tonically or all the time expressed in the brain, but does become expressed if the brain has been injured. So if there is inflammation, direct injury, trauma to the brain, we do see much more CB2 activation in the brain relative to CB1, but only in that circumstances. And so, if you look at all those bodily functions, we see endocannabinoid receptor systems pretty much throughout the body, thought to be involved in things like pain, memory, mood, appetite, stress, sleep, metabolism, immune function, and even reproductive function, which I think explains some of the concerns we have about chronic cannabis use, but then also some of the ideas on where cannabis products might be therapeutic. Just to be clear, right, now that we know that vertebrates have this endocannabinoid system, we do have our own endogenous ligands that interact with these receptors. And so our endogenous ligands are named 2-AG and anandamide, or AEA, sometimes how it's shortened. These were discovered primarily starting in 1982 with anandamide. And these kind of correlate a little bit when we think of cannabinoids. We're thinking of similar substances that are more found in the plant. And so THC and CBD are cannabinoids, whereas endocannabinoids are endogenous anandamide and 2-AG. But all sets of those substances are thought to interact with these receptors in the endocannabinoid system. We talked about the endocannabinoid system being associated with bodily homeostasis, in which case what that means is they really function as this really tight regulator and modulator of a lot of different systems in the body. So for example, this is a picture of a glutamate receptor, a presynapse and a postsynapse. And so different than a lot of other neurotransmitters. So if we think of things like serotonin, norepinephrine, dopamine, most of those are created and they're stored in vesicles. And when prompted, those vesicles go to the surface of the presynapse and they release into the synapse to have some sort of downstream effect. On the flip side, endocannabinoids are actually created on demand. So they're not created ahead of time. They're created in real time as a reaction to something, which provides a lot tighter of a regulation. So for example, this is a presynapse. There is some sort of release. We have glutamate in the synapse. The glutamate interacts with the NMDA receptor, which then downstream prompts anandamide to be created. Once anandamide is created, it interacts with the CB1 receptor and it turns off this intracellular target. So there's no more glutamate that's released into the cell. It interacts with some other receptors that are thought to be part of the endocannabinoid system. And then ultimately, after its signaling is done, it's taken back up into the postsynaptic cell. It's broken down into its components, and it doesn't hang around any longer than that. So again, you kind of get this real-time creation, real-time activation to help maintain homeostasis, and then it kind of goes away. We do have some products that are cannabinoids that are FDA approved for various indications. The first one's being in 1985. So just to go through these, dronabinol is a synthetic THC product. It's a partial agonist at the CB1 receptor. It's been FDA approved for things like chemotherapy-induced nausea, vomiting, and to help with appetite stimulation and wasting conditions, for example, HIV. The second FDA-approved cannabinoid is nabilone. Nabilone is also a synthetic THC analog. It has partial activation in both CB1 and CBD2, and it has indication for chemotherapy-induced nausea, vomiting. And then cannabidiol is sometimes its brand name is Epidiolex. This is actually a CBD only oral solution. In contrast to dronabinol and nabilone, it's actually derived from the direct cannabis plant. So although it is considered a CBD only substance, because it's derived directly from the plant, there can be trace amounts of THC, just not really enough to necessarily have a significant amount, but potentially enough to trigger things like a positive drug screen. And this has mainly an FDA approved indication for different seizure disorders. So again, we already have some products. Reminding you that the CD1 receptor was first identified in 1988. So we had some of these products before we even had an awareness of maybe which receptors in the body we were utilizing with some of these medications. Now, in 2017, the National Academy of Science, Engineering, and Medicine, they were appointed or kind of tasked by the government to create a committee of about 16 people, and they were tasked with having to review the health effects of cannabis, the potential therapeutic benefits, and to help create kind of a research agenda around cannabis. They published their results in 2017, so this is kind of a summary of their results. And I have 2 slides. It's a very long report. It's very comprehensive. They cite their opinions very well when it comes to conclusions that they make throughout the guideline. But they kind of, I included in these tables things that were considered to have level of evidence of either moderate or substantial. And so this slide talks mainly about things that are definitely associated risk of cannabis. And so there's substantial risk of cannabis causing respiratory symptoms, motor vehicle crashes, lower birth weight, and psychosis, especially dose dependent, especially with THC. There's a moderate level of risk that cannabis is associated with things like pediatric overdose, impairments of learning and memory. It's pretty harmful to things like mood disorders, whether that's bipolar or more depressive disorders, anxiety disorders. And then obviously there's a moderate risk of cannabis producing cannabis use disorder. If we then look at the opposite side, so level of evidence, substantial or moderate, that cannabis might be effective or has some benefits to certain conditions. They said there was substantial level of evidence in this report that cannabis could help chronic pain in adults, for that chemotherapy-induced nausea, vomiting, and for symptoms of spasticity in people with multiple sclerosis. There was moderate level evidence that it could help with short-term sleep outcomes and a few different chronic health conditions, so sleep apnea, fibromyalgia, chronic pain, and that it actually helped perform better cognitive performance in people who had psychotic disorders. And this was primarily CBD. So CBD does have evidence that it can help with some of the cognitive impairment that we associate with diagnoses like schizophrenia. Now, the National Academy came out with an updated policy statement around cannabis. This was not the same goal. So the goal of this policy statement was to really look at cannabis availability, regulatory framework, and kind of the health equity impacts of cannabis. So it was not the same report or the same task from 2017. And based on this report, they really wanted Congress to say, hey, we need to define what hemp is, so that THC and kind of different cannabinoids, especially these like synthetic cannabinoids, we need to make them not exempt from the Controlled Substances Act. So we need to have more regulation about these different variants of cannabis that were available. They wanted the CDC and the NIH to come out with best practices for the states. How do they surveil their programs? And they really promoted funding research around cannabis. We just don't know enough from a research perspective about cannabis, whether we're talking about therapeutic or just kind of more direct health impacts. And then from a state level, they recommended in this report that there was more product quality enforcement, more retail staffing and training, that there was better messaging around cannabis from a state level. Now, again, outside of kind of going through a lot of different, in my opinion, very messy literature around cannabis, I've chosen some pretty high-level systematic reviews of medical cannabis products, which I think give a better overview. If you're just talking very broadly with someone about medical cannabis and what we know, I think these meta-analyses and systematic reviews do a much better job of giving just a broad messaging around how to use these products. And so this information about health outcomes was mainly taken from Australia. They looked at a lot of their medical cannabis products, but they did use information about different medical products from a lot of different countries. And I think what really I want to point out is in the blue boxes. And so ultimately, if THC is going to be helpful for a condition, it tends to be helpful at lower doses. And they define that as being 0.1 milligrams per kilogram per day. So, if you think of someone who's a 70, kilo adult person, that's maybe 7 milligrams of THC per day. In the flip side, if CBD is going to be helpful to someone, it's going to be helpful at actually higher doses. So even as much as 50 milligrams per kilogram per day relative to lower doses. And if you have a combination product that has both THC and CBD, products that have a 1-to-1 ratio had the most beneficial effect. There's aspects of CBD that help to modulate how much THC is allowed to interact with the CBD receptors, the endocannabinoid system. It almost acts like a little bit of a shield from some of the more harmful parts of THC. And so mixed products 1-to-1 seem to have a more beneficial effects compared to if you use really high THC products with CBD or really high CBD with THC. If people use more than that, so if they use more, for example, of the THC at that 7 milligrams per day, what they notice more just side effects than benefits. So things like somnolence, dizziness, drowsiness, headaches. So people just don't feel well. And they're also very clear through multiple systematic reviews that THC in any amount is just not recommended for certain populations. So we don't recommend it for children or adolescents. There's just too much brain development to be exposing that to THC. If people have either a family history or personal history of psychosis, even if it has nothing to do with cannabis, if there's history of psychosis, that really should not be a population exposed to THC. And then if you have a history of angina that's felt to be cardiac in origin, and then a history of myocardial infarction, those are also populations that THC exposure was not recommended. So again, broad scheme, if you're going to find benefits, you tend to find benefits at lower THC amounts, higher CBD amounts. If you have mixed product, 1-to-1 ratios are best. And then people who are younger and have, histories of psychosis or history of cardiac abnormality should really not be using THC in particular. Now let's zoom out, right? So those were maybe more individual type of risks and kind of dosing requirements. If we zoom out to more of a public health view, there's also been a lot of systematic reviews that have looked at, well, what do we know about the impact of legal cannabis availability in different places? And so this was mostly from studies in 2023 and 2021. And basically what they noted is that places that had increased availability of legal product, there tended to be more prevalence of use. That makes a lot of sense. More availability, more people are going to be potentially using it or trying it. If there was more availability in a legal stance, there tended to be more risky use. So potentially people using it and driving and using it in ways that they shouldn't. They did make a note, though, that it was only in an illegal market that tended to be associated with people developing a cannabis use disorder. So where you tease out more risky use and cannabis use disorder, they made a distinction, at least in this review. And then the more available the product is, the more health problems people would have. So the more things like ER visits for untractable nausea, vomiting, and psychosis, things like that. Now, with all that being said, though, I think it's also to keep in mind that all of those things are also true with alcohol. So the more widely available alcohol is, the more retail options we have, the lower the prices, the more days of the week, the longer the hours that liquor stores are open. That also tends to increase to more use, more risky use, potentially more use disorder, and more health problems related to alcohol. So very similar from a public health perspective, in which case we know a lot about some public health things that help to reduce the harm caused by alcohol. And I think a lot of those public health things could also be applied to cannabis. The other thing that I pointed out a little bit earlier, but I wanted just to reemphasize, that legalization of cannabis products, especially edible products, definitely are associated with increased risk of pediatric toxicity. Again, they look like candy, they're colorful, they're inviting. There's sometimes mirrored behavior where children will see an adult utilize one of those substances. And again, the packaging looks colorful and candy-like, and so they think it's going to be appropriate for them as well. There are increased risk of toxicity because toxicity tends to be weight-based. And so if you take the same dose as your parent and you are of lower weight, you are definitely going to have a higher risk of toxicity. The treatment's mostly supportive. People are informed there are state poison centers just so they can keep track of different unintentional injuries and ingestions. And then different prevention things are being put in place. So, childproof packing on edibles in particular, recommending that people kind of store their product in a safe place, a locked place, to not use in front of children, again, to not model some of that behavior that can be misconstrued by young populations. And then more of an emphasis on even putting warning labels on edible products in particular to try to reduce that unintentional injury. When we think about what's the risk in medical cannabis products in particular of neurocognitive impairment, there's not really a lot of, I would say, definitive literature about this so far, especially in adult populations. If there's neurocognitive impairment over long periods of time, it tends to be with people who are using products that are moderate to high in THC levels. It tends to be more commonly seen in people who are chronically using rather than people who use for short periods of time intermittently. And then the earlier you have onset of cannabis use, especially chronic use, the more likely you're going to develop a neurocognitive impairment later on in life. So again, very similar to how I think we perceive other substance exposure in general. So the more potent, the more chronically you use it, the earlier you start, the more impacts we see on the brain. The last thing I want to talk about as far as just impacts is driving, because I think this comes up a lot, and this is something that I talk to people about if they're using cannabis products or if, whether it's medical or otherwise. So this is actually a really fun study. So this was a study that was published in Addiction, which is one of our hallmark addiction medicine journals in my field. It was published in 2022. And really what they were trying to do is they were trying to quantify the magnitude of how much cannabis and alcohol alone, and then how much in combination they affect driving performance. And so they basically only took data from experimental driving settings. So driving simulators, closed course tests, on the road tests. So this was not necessarily broad looking at traffic data. This was very controlled settings of experimental driving studies. It included 57 studies with over 1,700 participants. And what they found is people who were using cannabis tended to have impaired lane excursion, which means, if you had your two lines of your lane, you tended to kind of do a little bit of a side to side, not necessarily cross the lane, but you tended just to do a little bit less of a straight line between points in A and B. You tended to drive slower than the speed limit. So you tend to drive slower than you might otherwise if cannabis wasn't involved, but the variability of speed didn't change. So you tended to drive slow the entire time. This is very different than alcohol. So when people were intoxicated on alcohol and driving, they tended to drive too fast and their speed variability changed very rapidly. They kind of quantified based on these simulation studies that cannabis exposure and driving was very similar to low levels of alcohol. So maybe about 0.04% as far as the blood alcohol level content. And that, as you might imagine, if you were utilizing both cannabis and alcohol, you performed worse on all of these different kind of hazard response times, lane excursion, speed variability. You performed worse if you used both of them together than you did on either one of them alone. So, really kind of pointing out that multiple substance intoxication in the driving is also, associated with more risk. So again, we talk about with people using cannabis that it's not safe. It definitely impacts your ability to drive. If you're driving too slow, obviously that maybe has a little bit less of a harm than if you're driving too fast in the setting of acute alcohol intoxication, but it definitely impacts your ability to react and be able to drive in the same way you would otherwise. All right, we're going to transition now to the Iowa Medical Cannabis Program. And I just want to, a lot of the information, especially the details, are from our latest annual report, which is publicly available or will be publicly available within the next month or so. So if you're interested, feel free to check this out. This is actually a picture that I took from one of the cannabis manufacturers in the States. There's two companies that have licenses to do manufacturing in the States. So this is just a picture from one of their growing facilities. So just from a historical perspective, in 2017, Iowa passed the law that was Iowa Chapter 124E, and this basically legalized the manufacture and sale of cannabis products that could contain both CBD and THC. You had to be a registered card holder in order to purchase from these facilities and to possess these products. And in the law, it only gave licensing to 2 different manufacturers and 5 dispensaries. So there was restriction on how much dispensary and manufacture could be available, which is slightly different than some other states, which didn't necessarily have any sort of cap on licenses or how many manufacturers or dispensaries were available. Within that law, they also created a structure of a board. And so this is an advisory board. So the board has to be made up of 8 practitioners. They were very specific on what fields they wanted practitioners from. So you kind of see them listed out there. It's chaired by a law enforcement official, which again, very specific to how the law was written. And then the duties of the board, we don't necessarily make direct impact to the cannabis program. We are responsible for looking at petitions about different products, different qualifying conditions that people would like. We give recommendations to that, either to the legislature, but also to the medical board. And ultimately, any change to the medical program really has to come from the medical board or come from the legislature. So we don't necessarily have any direct impact on the board. We're in a very advisory role in that way. And then we're responsible for creating an annual report, which we should submit to the legislature on a yearly basis. So a little bit of a definition. So who could be a patient under Iowa's medical cannabis program? So, in theory, to be a patient, you could be of any age. So, we have pediatric epilepsy conditions that people can technically be a patient for the program. You have to be a permanent Iowa resident, and you have to have one of our qualifying conditions, which I'll show you in a minute. How do you apply if you're a patient? So there's a form that a healthcare practitioner has to sign. There's an application that you have to fill out. You submit them both online with a copy of your driver's license, then you have to pay an annual fee. If you're on disability income or Medicaid, it's $25 a year. If not, you are otherwise paying $100 a year, and that has to be renewed on a yearly basis. This is just a quick picture of at least what one version of the cannabis card looked like. So you can kind of just see just a little card, has some information, has your issued expiration date, things like that. This is what you would show to a dispensary, for example, if you were going to go purchase a product from a medical dispensary. Let's look at data, right? So at least since 2019, you kind of get the sense that there was a kind of a surge in how many people were considered active patients in the medical cannabis program. It's been a little stagnant, I would say, over the past 3 years or so. There's probably a few reasons for that. Probably the most common one now being the fact that when consumable hemp came on the scene in Iowa, a lot of people just kind of diverted using consumable hemp products versus away from the medical program because the medical products were just much more expensive. Of people certifying cards, nurse practitioners are kind of the highest type of healthcare provider that certifies cards relative to MDs or DOs at this point. If we look at age and qualifying condition of people who have been certified or are card holders, just to point out, if we look at age, most of people who are card holders are going to be in that 31 to 50-year-old demographic. That's the most common demographic that we see. If you then look on the bottom row, if you see it by condition, chronic pain is by far the most common reason why people get a card. And then you can kind of see that PTSD is the second most common indication for people getting a card. If we just go through the top, so these are all the qualifying conditions under Iowa's medical cannabis program. So AIDS and HIV, ALS, autism, cancer. We have both ulcerative colitis as well as Crohn's, chronic pain, multiple sclerosis, seizures, and then basically a generic terminal illness category. This is the graph from our most recent annual report that just shows by qualifying condition what's the most common formulation that's being purchased. And by and large, the high THC products are much more common than any other product. And that's kind of regardless of which condition you're looking at. So those orange bars are much bigger. Despite maybe counseling, despite what we know about maybe the benefits of CBD or CBD only products for certain conditions, when people walk into those dispensaries and there's not necessarily a medical provider available, they're much more likely to purchase the high THC products. This just shows how many waivers are issued. So, sorry, just to give some background, when the law came out, there was a limitation on how much THC people could purchase. And so the limit in Iowa's law was 4.5 grams per 90 days. So, that's about 50 milligrams per day of THC that someone could purchase over a 90-day period, which if you remember my graph, that's still a lot of THC relative to how much we think is actually needed to gain benefit versus how much harm people can get over that 7 milligrams per day, for example. And a few years ago, there was a mechanism was changed within the program, mainly by the legislature, that people could get a waiver filled out. So the person who filled out your card could also fill out a waiver, and they could basically, it was kind of a blank check. They said that you could basically purchase as much product THC that you wanted to. And so this just shows how many people have actually been utilizing that waiver. So as of 2025, we had about 4,500 people who had a waiver, which was about 27% of cardholders. So, about a quarter of people are actually have the ability, if they want to purchase more THC, based on the restrictions built into the actual program. Which there's, I'd say historically, the past few years that I've been on the board, there's been a lot of discussion about that, and sometimes a little bit, I think a little regret over how that kind of happened as far as the THC waiver goes. What about if you're a healthcare provider? Like how liable are we if we are basically participating in a program that in theory breaks federal law, right? So I think there's a lot of questions about that. So in our state law, it says that a healthcare practitioner is not subject to criminal prosecution or any civil disciplinary penalties from the Board of Medicine or any other licensing board, as long as you are operating within the confines of the program. The DEA came out and basically says that the federal government was not going to mess with your DEA registration as long as you were participating in your state program the way that you were supposed to. So if you were following the state program, the DEA basically said, we're not going to get involved. We're not going to, engage with this system as long as you're doing what you need to from a state level. There's a question about malpractice, and at least based, as of 2025, there haven't been any reported cases of malpractice specific to people working within the state medical cannabis program. With that said, I think it's always good to talk to your practice, to talk to your legal counsel, your malpractice carrier, just to make sure that the risk is kind of felt to be low enough or in a way that's kind of acceptable to the group of people that you're working with and who your carrier is. These are some of the dispensary products that you might see. So if you go into the dispensaries in Iowa, there's things like tinctures, capsules, topicals. There are vaporizable products. There's liquid cartridges that you can either use in your own vaporizer or maybe one that you purchase at the store. They are not allowed legally to advertise these as being like sativa or indica or based on a strain. And so you'll see reports of how much CBD and THC is in each product. And then they tend to have these, very pleasant names like Calm and Soothe and Harmony, rather than maybe listing things by strain. What I will say is that every purchase at the dispensary is tracked by a centralized system, and the Department of Public Health basically it's notified in real time when purchases happen, how much is purchased, to make sure that the THC limit isn't overdone. And there's a lot of quality control that happens. So the Iowa State Hygienic Laboratory does product testing on basically all final products that are sold in Iowa. They test that there's an accurate amount of THC and CBD, so you can't just list off whatever you want to. It has to actually be verified by the hygienic lab. And they're also testing for contaminants, so things like metals, pesticides, etc. So they do a good job of being well-regulated, safer products as far as knowing what's in them and actually having the advertising match what you're actually consuming or what's being listed on the bottle. This is a graph that shows the states. So this is the numbers in each county talk about how many cardholders are in each county. I put little symbols as to where the 5 dispensaries are in the state. We have 2 manufacturers. We have Bud and Mary's. They have dispensaries in Polk County and Woodbury County. And then we have the Iowa Cannabis Company, which if you're in Johnson County like me, it's kind of on the south side of Iowa City, but then also in the Waterloo and Potawatomi, County area. As you can see by the color density or the darkness, places that have access to a dispensary, there tends to be more people with cardholders. We have been I would say the Medical Cannabis Board has been supportive of having more dispensaries available just to help with equity. So if you live in the northern central or the southern central part of the state, that you don't necessarily have to drive certain places. But so far that has not made it through into a legislative policy or law that has passed to date. I want to make a mention about consumable hemp because this is either something that you know about or people are talking about or patients are asking about. So again, we talked about that hemp is a type of cannabis that has less than 0.3% THC. In Iowa, there was the Hemp Act that was passed in 2023. I'm going to go back in order. So the Farm Bill was passed in 2018, which basically made consumable hemp products more available or realistic. The Iowa Hemp Law Act that went into 2023 allowed there to be basically THC products that were 4 milligrams of THC per serving or 10 milligrams per container. It could include edible products, such as kind of what's pictured here is like seltzer drinks. These climbing kites is one of the brands or one of the types of products. But they banned inhalable hemp products, and you couldn't mix alcohol with cannabis. So you couldn't make a seltzer drink that was both alcohol and cannabis containing. That was also against the 2023 law. And then I've been reading a lot about this if you're not paying attention to drug policy per se, but in the Continuing Appropriations Act that was passed in 2026, kind of this short-term gap to keep the government funded, they actually threw in a lot of some legislation that had previously been taken out, but really it's going to really impact the hemp industry at this point. So they changed the hemp to define as any THC and basically all derivatives that contain more than 0.3% THC on dry weight. That basically means that a retail ready product cannot exceed more than 0.4 milligrams of total THC per container. So very different than the 10 milligrams per container that had previously kind of been available through the Iowa Hemp Act of 2023. It bans all synthetic, all converted cannabinoids, and that kind of took effect November 12th. And so, it's going to take effect November 12th of 2026. And so there's a lot of reaction in the hemp industry as far as what they're going to do. Certain states have a very active hemp industry. And so there's been a lot of outcry that there's a lot of industry that's going to be impacted by this Continuing Appropriations Act that was kind of thrown in at the last second. All right, my last few slides, I'm an addiction medicine specialist. I'm a psychiatrist. I also participate in I have certified cards for people. And so I do have these conversations with people. And I think my approach, if it's helpful, I do try to be trauma informed, try to understand what people's expectations are, what they're hoping to get. If at all possible, I try to say like, hey, maybe we have a different solution or a different intervention for this thing that might be more helpful. I try to, again, understand their reasonings for it. And then if, we talk about their comorbidities, right? So if I have a patient who has schizophrenia, I don't certify a card for them. I basically say, this is just really all harm and no benefit. And I really just can't participate as a healthcare provider. I care about you. I care about your safety. This is not how we're going to do it. If we end up providing a card, I try to have a really good discussion about risk, discussion about how, the route of use based on the qualifying condition and maybe product type, really trying to emphasize mostly CBD products. I don't really enjoy the vapable, inhalable products. So I do try to steer people to either more topical or oral consumption if that's based on their indication. And then we have a huge discussion about the legal limitations of the program. And this is my last slide for you guys from a formal perspective. So things to know about with the Iowa Medical Cannabis Program is driving, kind of the issue with driving and using any sort of Iowa medical cannabis products is pretty much the same as alcohol or any other prescription medication. Okay, so if you get pulled over and there are behaviors that make them think that you are driving while intoxicated, if they think it's because of your medical cannabis, and like having a card will not protect you from that. So in the same way, if you take a prescription medicine and you get pulled over for an OWI, you're still potentially going to have legal involvement, even though that medication is a prescription. And so same applies to the medical cannabis products. In Iowa, there's no protections from an employment perspective. So if your employer says that we're going to do random drug testing, and if you are positive for THC, you will get fired. Even if all of your medical product, even if all your THC is from a card, like a medical cannabis product, and you have a card, it doesn't matter. You can still get fired. It will not protect you. And while it remains federally Schedule I, even the American for Disabilities Act does not protect you, even if you're using from a federal perspective. So again, from an employment perspective, I tell people like having a medical card does not protect you from getting basically fired or having some sort of consequence if you are tested for cannabis and you are positive for THC. If you are under some sort of legal supervision, so probation, parole, again, no built-in protections. And really how you might get reactions based on medical cannabis use might be dependent on your supervising officer or whoever's overseeing you. So there are some officers that say, hey, as long as you have your card and you're doing everything else you're supposed to be doing, I'm not going to pay any attention to your THC positive drug test. There's other officers that say, hey, I'm pretty strict. This is federally illegal. I don't care if you have a card. If you're positive for THC, I'm going to kind of act on that and potentially revoke your probation. If you have family supervision, aka if you have child protective services, DHS involvement, same applies. So there's really no built-in protection if you're using the medical cannabis system, and that if the supervising agency says, hey, you can't use cannabis, if you are positive for THC, your medical card does not necessarily protect you from any negative outcome with that. So again, just the restrictions of protection, even if you're like doing everything else within the medical cannabis system. And then travel. So we have states surrounding us that all have cannabis potentially more widely available. Other states tend to have a reciprocal relationship with our medical cannabis card. So if you have an Iowa card, you can go to Illinois and purchase from their medical cannabis program. But the moment that you bring that product across state lines into Iowa, you are technically violating state law. And you cannot legally possess that because it was not purchased from an Iowa-related dispensary. So I also just caution people with that you have this card, but it does not necessarily protect you if you're in possession of any cannabis product that is not purchased from our dispensary in the state. So again, just some legal limitations with that. Okay. That was a lot. Again, hopefully it kind of gives a broad overview of what we kind of sense about cannabis and a lot of the limitations of what we know or don't know about cannabis from a medical perspective. And then also just a big overview and update about Iowa's medical cannabis program in a way that helps you be more helpful to your patients or even to each other if there's questions. My emails here, our University of Iowa email is here as well. So if there's ever any questions, feel free to reach out to me. I'd be happy to take any questions now or later.
Not seeing any questions right now.
Okay.
All right. I will share your email and I will make sure to share that handout that you sent me earlier to folks to check out as well. And thank you. That was amazing.
Of course. Thank you so much for having me. I appreciate it. I hope everyone has a great rest of their week and holiday season.
You as well. Thank you so much for joining us.
Thank you. Of course. Bye.